Thank you, Binay. So I just want to start by thanking Binay and the organizers for giving me this opportunity. And I also want to congratulate them for what looks like a very successful session with a great crowd. So I'm going to be talking about melanoma, and here are my disclosures. And just want to summarize the amazing progress that we have had in melanoma over the last, 7, 8 years. So this is the status prior to 2011. We had dacarbazine that was approved in 1975. Highdose IL-2 was approved in 1998. And both these therapies had no proven overall survival benefit. And the reference at the bottom is a review article that I wrote mostly to make myself familiar with the dismal state of affairs in melanoma. And it got published in a throwaway journal, which probably nobody reads. But it turns out that it was a very productive use of my time, because for all the subsequent successful publications, it gets cited as the benchmark for what did not work for melanoma. So I was never really expecting so many citations, but it has really turned out to be very productive.
I read that journal all the time.
You do? Okay. So this is the state of events in melanoma right now. So as you can see, since 2011, there have been so many drugs that have been approved by the FDA, both in the immunotherapy arena and as well as in the chemotherapy arena. And so with so many options, now we have the happy problem of which one to choose for our patients, when to use, how to sequence, and all those very important questions. So before we go any further discussing those important questions, here's a case. It's kind of worded long, but hopefully you can read it as I say the case. So 75-year-old man has a lot of symptoms, constitutional symptoms, and right-sided abdominal pain that has started recently. Imaging studies, as you can see on the scan here, show widespread metastases, but most significantly in the liver with more than 50% involvement. Brain MRI shows 5 metastases scattered in different parts of the brain. The largest was 1.5 centimeter in the right frontal lobe. There were no neurologic signs or symptoms, and biopsy of a liver tumor shows metastatic melanoma with BRAF mutation present. And laboratory studies, slight anemia, mild transaminitis, high alkaline phosphatase score of 375, bilirubin 1.5, performance status affected by all the symptoms, and a STU. So this is, by the way, the only question that I have. So I would, if you don't answer, or if you answer wrong, your score could be 0%. So just keep that in mind. So these are the options. So first is whole brain radiation therapy. Any takers for that? Couple. PD-1 blockade, pembrolizumab or nivolumab, your choice. Epi plus Nivo, so combination immunotherapy. Okay, 1. BRAF plus MEK, quite a few. And hospice, a few people there as well. All right, so we have whole brain radiation therapy, BRAF, MEK, and hospice as the front runners here. People are not choosing immunotherapy here. All right, I have another question. I'm going to actually skip it in the interest of time. So let's start with immunotherapy. So as you know, anti-PD-1 agents are approved for melanoma, and they are actually regarded as the standard of care for immunotherapy of metastatic melanoma. And we have 2 agents approved, pembrolizumab and nivolumab. And both of those got approved when the superiority over ipilimumab was proven in randomized clinical trials. So this is the data of pembro versus ipi. So the response rates, as you can see, they were almost 3 times as much with pembro over ipi, but toxicity was better. So it was a win-win on both fronts, works better, lower toxicity. Same data with Nivo, much higher response rates, and lower toxicity as compared to Epi. So these two trials led to PD-1 monotherapy being regarded as superior over Epi and should be used upfront based on this data. I don't see any reason why we should use Epi monotherapy upfront for metastatic melanoma based on this data. So we also know from now long-term analyses of Epi follow-up that patients who do well with immunotherapy early on, they actually have a very good shot at becoming long-term survivors. So this is the data with Epi. Again, the response rates are around 20 to 30%. But most of those patients who have benefited early, you can see they are actually alive 10 years later. 20% 10-year survival rate with Epi. This was from the early Epi data. And now with the success of PD-1 monotherapy, you can see that this proportion is actually higher. So 34% 5-year overall survival rate in this analysis. This is with anti-PD-1 monotherapy. And we also know that the combination of Epi plus Nivo is approved almost 2 years back. And in this combination, Epi is given at the 3 milligram per kilogram dose, Nivo is 1 milligram per kilogram dose, given in combination together every 3 weeks for a total of 4 doses, the so-called induction phase. And after the induction phase, you do maintenance immunotherapy with nivolumab given every 2 weeks. And this approval was based on this data. So it was a 3-arm trial comparing Epi versus Nivo versus the combination. And as you can see, as compared to the Epi and even Nivo, the response rates with Epi plus Nivo were higher, but also the toxicity was much higher as well. So those two things suggest that you do get greater immune activation if you combine the two drugs. But because of this really high toxicity rate, that really puts into question, is it really worth it? And that's what we need to answer at this time. So the questions that I'm going to try to address in this talk today is first, what is the role of combination therapy with Epi plus Nivo? Second, is it safe to stop therapy with anti-PD-1 in patients who are responding? Also, how to treat patients with brain mets. So remember our case had 5 brain mets. And then last, what I'm not going to be able to address today due to lack of time is, but it's the most relevant question, is what should we do in patients who are not responding to PD-1 monotherapy? And there is an immunotherapy session later on, so hopefully some of those options will be discussed over there. So what is the role of combination therapy with Epi plus Nivo? So this is where the New England Journal publication had left us. So you can see the top 2 curves here are PD-1 monotherapy and the combination, and the bottom curve is Epi, and this is relapse-free survival data. So this was in 2015. We did not have overall survival data. And it was suggested that if we use PD-L1 expression level, maybe we can identify a population where we might get more benefit from the combo as compared to PD-1 monotherapy. So this is the right side here. Patients with low PD-L1 expression, you can see potential advantage with the Nivo plus Epi arm over PD-1 arm. So there have been updates recently. So the AACR meeting earlier this year came up with this headline: combination of nivolumab and ipilimumab improves overall survival in advanced melanoma. And it might sound like, okay, we have now met overall survival improvement with the combo, but I think if you read the fine print, the improvement is as compared to Epi and not as compared to the PD-1 monotherapy. So this is the curve that was presented at the meeting. So again, the top 2 curves are combo and the PD-1 monotherapy, and the bottom curve is Epi. So you can see significant overall survival improvement over Epi, but between the top 2 curves, there's actually not much to choose. If you look at just the raw figures, maybe there's 5% survival benefit at this time point, but not before, and doesn't look like afterwards. So why is this time point more important than this one? I don't know. But I think it's fair to say that there is no substantial survival benefit with the combo over PD-1 monotherapy, at least at this time. Then we have to do subset analyses to find something interesting and suggest it to the clinicians. And so again, looking at that PD-L1 expression data, it has been suggested that if the PD-L1 expression is low, maybe you get more survival benefit with the combo. But on the other side, actually survival is worse with the combo if you have high PD-L1 expression. But I want to remind, both of these are not statistically significant, and we cannot make any conclusions. At this time, I don't think we should use PD-L1 expression status to select combo over monotherapy. Another subset analysis shows potentially better outcomes with the combo in BRAF mutant patients. And again, I think we have to be interpreting this very, very carefully. So my conclusion on these results are that there is no significant survival benefit to the combo over PD-1 monotherapy. These subset analyses are interesting, but they warrant further confirmation. The higher response rates and toxicity that we see with the combo, they do suggest that we are getting more immune stimulation with the combo. But we really have to view that in the context of patient goals of care and the patient preference. Some patients want to be the most aggressive possible, and I think it's okay to discuss the combo in those patients, but we really have to prepare them for the high rate of toxicity that comes with the combo. But there's also room for improvement here. So we can definitely optimize the combination further, and those efforts are already ongoing. So there are trials that are using reduced dose of Epi at 1 mg per kg instead of the 3 mg per kg, which was used in the FDA-approved trial, and also reducing the frequency from every 3 weeks to maybe every 6 weeks or something like that, where you do add some extra immune stimulation, but maybe not at the cost of much higher rate of toxicity. So data from those trials will be very informative in determining the fate of the combo as it stands now. But also these data highlight the importance of more work that needs to be done. I think we want to find treatments, immunotherapy treatments that work better with the PD-1 monotherapy at this time. Epi Nivo may not be the answer, but there are so many other newer targets that are being tested. There are actually frontline trials already going on with IDO inhibitors plus PD-1. Intralesional TVEC plus PD-1 is also being compared to PD-1 monotherapy. So trials like those could offer useful alternatives to the Epi Nivo. So second question that comes up in the clinic all the time is it's actually a problem of our success. People are doing so well on these agents that they are becoming long-term survivors. Now, most of the trials with the anti-PD-1 monotherapy had treatment scheduled for up to 2 years. Some trials had treatment scheduled for indefinitely, but the question comes up, in a person who's responding, is it safe to stop treatment, especially when they're doing so well? And when we know the alternative is not good, if their cancer comes back, that could be a life-threatening situation. And patients are nervous and clinicians are nervous. So do we have some data to guide us in that area? Yes, so 2017 ASCO, we had this presentation on long-term outcomes in patients who had received pembrolizumab. And in this trial, pembrolizumab was scheduled to be stopped after 2 years. And what the trial suggests is that if you look at the progression-free survival here, these are patients who have stopped pembro after completing either 2 years or they came off due to toxicity reasons. And you can see the vast majority of patients continue to be progression-free with a follow-up period of median follow-up period of around a year after stopping treatment. And they break it down by response status too. So patients who have had complete responses, partial responses, but even patients who have had stable disease as their best responses, the vast majority continue to be progression-free after stopping pembrolizumab, suggesting that it might be safe to stop treatment We always have the option of restarting treatment, or if the tumors progress, possibly prioritize those patients to get some novel combination immunotherapy rather than continuing what is working, but what did not work quite as optimally as we would like it to. So third question, how to treat patients with brain metastases. And there were 3 very interesting abstracts presented at ASCO, which are, I think, probably paradigm changing as to how we think about brain mets, especially at least for melanoma, and potentially for other cancers like lung cancer as well. So the first one was a phase 2 study testing nivolumab plus ipilimumab combination in patients with brain metastases. And the chief criteria for eligibility here was that patients had to have asymptomatic measurable brain metastases less than 3 centimeter in size. All the patients got Epi Nivo combo with potential maintenance nivolumab. And the responses are pretty outstanding, as you can see. So just focusing on the intracranial response, 21% of the patients had complete responses. Another 33% had partial responses. So if you look at the overall response rate, it's more than 50% in brain metastases. And the clinical benefit rate, which also includes stable disease, was quite substantial as well. So this suggests that immunotherapy effects can cross the blood-brain barrier. They can actually lead to intracranial tumor regressions. And similar to what we see systemically, these responses seem to be very, very durable. The vast majority of responses are ongoing at the time of this report without any progression. So immunotherapy can lead to durable responses in the brain, which is quite a dramatic development. So this is just an example of a patient who had a tumor here with quite significant edema around it, and 1 year later, you can see the complete resolution. The second study actually uses nivolumab monotherapy or the combination, again, in patients with brain metastases. And they had 3 cohorts. So the 2 cohorts shown here in these colors are with patients with asymptomatic brain mets. The cohort C actually included patients who had previously treated or symptomatic brain mets, and that cohort was treated only with PD-1 monotherapy. And these are the response rates. So again, Epi Nivo seems to be working really well with a very high response rate. But actually, surprisingly, and you see much lower response rates with PD-1 monotherapy. And in patients who had symptomatic brain metastases or previously treated, the response rates were even lower. So this suggests that if you have to use immunotherapy for asymptomatic brain mets, probably Epi Nivo offers you the best chance. Again, these are small numbers. We have to view more data before we make definitive assessments. But these are the best data that we have so far and something that we should consider. The third study uses targeted therapy with BRAF/MEK, again in patients with brain metastases, and quite a number of different cohorts. There was one cohort with symptomatic brain mets, others were asymptomatic, and what you can see here is quite remarkable. The vast majority of tumors in the brain, they are shrinking once you use BRAF/MEK. Again, not only the effects of immunotherapy, but also the effects of targeted therapy are crossing the blood-brain barrier to lead to intracranial regressions. And the high objective response rate in all cohorts, including symptomatic cohorts, also suggests that this is probably a very reliable option if you want immediate response. So if you have big, bulky brain metastases, multiple areas, this is much better than probably whole brain radiation data. So I think it's time to start thinking of brain metastases as a systemic problem and not just reflexing to the use of radiation. So my conclusions on brain mets, melanoma brain mets are responsive to systemic therapy. Immunotherapy with Epi Nivo has impressive responses with durability in patients with asymptomatic, relatively small brain mets. Now, BRAF-MEK can lead to prompt and reliable intracranial tumor regressions, and it offers a reasonable palliative approach, although we don't typically expect durability in those responses. And lastly, we should critically question the role of palliative radiation therapy, especially whole brain radiation therapy, which is actually now becoming a problem for some of these patients who get whole brain radiation therapy. They get subsequent immunotherapy, they become long-term survivors, and then you start seeing what I had never seen before, the long-term cognitive effects of whole brain radiation therapy. Most of these patients would typically have died within 3 to 5 months, and you never saw those long-term consequences. But I have actually a couple of patients who have lived 7, 8 years out, and they are behaving like Alzheimer's patients, which is tough to watch because their cancer is in complete remission. So the $64,000 question, what to do in PD-1 refractory patients? All I'm going to say is there are numerous clinical trials that are ongoing. Almost all of those trials have the flavor of adding drug X to PD-1. Drug X, numerous companies are investing into that drug X right now. So that's a good development. People are now buying into immunotherapy and putting in resources, and good things are happening. And hopefully next year we will have some definitive data as to what works well in PD-1 refractory patients. But also it points to the need for developing biomarkers to know when the PD-1 monotherapy will work or not work, so we can prioritize treatment of those patients as needed. So last but not the least, there are some big news about to come in adjuvant therapy department. So why is adjuvant therapy important for melanoma? So you can see these are the survival curves for patients with localized melanoma on your left side, and for patients with regional metastases on the right side. So even patients who have localized melanoma confined to the skin, you can see 2B, 2C, which represents high-risk primaries, generally thicker tumors with ulceration present. The percentage chance of dying from melanoma over the next 10 years is very high, 60 to 70%. So this is for patients whose cancer hasn't spread to lymph nodes, and we might think that the problem is gone with just aggressive surgery, but these patients have a very, very high risk of recurrence. And unfortunately, most of these early stage patients are excluded from most adjuvant trials, but I think as a field we need to change that, and we need to include these patients in our adjuvant studies. But regardless, at this time, I think it's something that you should keep in mind when you are developing surveillance plans for these patients. There is a high risk of systemic recurrence, and possible systemic surveillance is warranted in these patients. Now, patients with lymph node metastases, 3A represents patients who have only sentinel lymph node metastases detected by sentinel lymph node biopsy, and the prognosis is actually quite good. But for patients who have either a high-risk primary or clinically detected lymph node metastases detected as suggested by 3B and 3C, they have quite poor prognosis, and those patients are generally the patients who are included in adjuvant trials. So what is the current standard of adjuvant therapy? I don't know how many people still use interferon, but I haven't prescribed it in 5 years, and I'm happy about that. High-dose Epi is, I would regard as the current standard of care when we think about adjuvant therapy for melanoma. And this was approved in 2015 for patients who have pathologic involvement of regional lymph nodes of more than 1 millimeters. So stage 3B, 3C disease generally is what was included in that trial. And the dose is 10 milligram per kilogram. So reminder that metastatic Epi dose is 3 milligram per kilogram. So this is a high dose Epi, and it's given as in an induction phase every 3 weeks and then a maintenance phase every 12 weeks for up to 3 years. And these are the data that led to the approval. This was compared to placebo, and you can see improvement in recurrence-free survival, maybe around 10 to 15% benefit. However, high-dose Epi has several problems. So the toxicity rate is quite high. If you look at grade 3 or higher immune-related adverse events, it's more than 40%. There are people who have died from high-dose Epi too, although the rate of life-threatening complications is quite low if you follow these patients carefully. Cost is an issue as well. If Epi is so expensive that the approximate cost of 3-year course at the current prices is $1.5 million, and you can ask whether that small benefit is worth it. The other problem with the high-dose Epi was that the benefit was in relapse-free survival. We did not have overall survival benefit. This is all about to change. So there has been a recent press release about the other phase 3 study, which was comparing nivolumab to high-dose ipilimumab, has met its primary endpoint of improved relapse-free survival. So that data is not public yet. It is going to be presented soon. Hopefully will be a positive result. But I would imagine it to be something like this, where the placebo is here and high-dose Epi led to some improvement, and now this trial hopefully will show the curve shifting even further higher up. And hopefully with curves like this, we will be able to treat melanoma preemptively in the stage 3 setting so as to prevent stage 4 disease completely. So there is another trial that is going on right now, which can actually make PD-1 monotherapy available to your patients in the adjuvant setting. So this trial currently has 3 arms. Nivolumab monotherapy is 1 arm. Nivolumab plus low-dose Epi, not the combo as approved for stage 4, but low-dose Epi, which probably optimizes the combination, and comparing it to high-dose Epi. But with the recent press release, the high-dose Epi arm is being dropped. So the trial will make PD-1-based therapy available to your stage 3 patients ahead of its FDA approval, hopefully. This trial is available at SCCA. If you have any patients that could benefit from it, certainly feel free to let us know. And coming back to our case, and I think I am right on time. I have 2 minutes to finish this case. So again, 75-year-old man who has a lot of constitutional symptoms, bulky liver metastases, asymptomatic, multiple brain metastases, a little bit of liver dysfunction, which suggests that the liver might actually start to fail. Performance status is being affected. So what are our options here? So any changes, anybody who would use whole brain radiation therapy, PD-1 blockade, Epi plus Nivo. Okay, so a few people have changed their options here. So Epi plus Nivo, BRAF plus MEK. Okay, so again, I think the BRAF plus MEK is winning. Hospice. All right. Okay, I think it's for patients, unless it's patient preference, I feel like as a clinician in melanoma clinic with access to all these therapies, hospice is probably not the right option for melanoma, because even with all these success, we can actually get durable responses in a subset of patients. So trying something is not completely unreasonable here. And I would agree. So this patient has quite a few problems. The liver is failing. If we what we need is something to work reliably right away, and I think BRAF plus MEK is our best option for that. We can use immunotherapy if it was a BRAF wild-type patient. I think that would be perfectly reasonable, but we have to remember that immunotherapy doesn't work right away. It takes a few weeks to kick in, and also it has probably a 50-50 chance of working. When it works well, when it works, it can work really well. When it doesn't work, it is not gonna work. So if you want reliable tumor regression, BRAF MEK is your best option. But then you have to also remember that those responses are probably not going to be very durable, so you probably want to transition to immunotherapy after you have stabilized the patient. So with that, thank you for your attention. And I guess we'll take questions later.